Okay, so now I'm going to post something a little bit more provocative even than my last video. So in dealing with COVID, we really have two things that we could do. We could develop treatments and we could develop a vaccine. Treatments is to give to somebody who already has COVID, and the goal is to prevent the person, of course, from dying or from going to the ICU or for speeding up to recovery. And it's only given to sick people. That's a treatment. A vaccine is to prevent people from getting COVID to begin with, or creating this notion of herd immunity, that enough people in the community can't get it, and thereby maybe even eliminating COVID, because the probability of transmission will be lower and lower as more and more and more people simply can't get it. The vaccine is a preventive measure given to all people, all healthy people. What I want to argue today is that for vaccines, you need very strong EBM, or very strong evidence-based medicine, because you're giving it to healthy people. You could do harm. But in the context of an acute pandemic, where people are getting acutely ill, my argument is going to be that we're applying a very high standard of evidence that may be better for chronic disease and may not be the best standard to apply during a pandemic and may be slowing things down. There's no doubt that there's been a revolution in medicine toward this thing called evidence-based medicine that requires a very high standard of evidence in order to validate whether a treatment is good. And I would argue that that's good for things like treatments for diabetes, which is a chronic disease. The complications are a little bit hard to trace back. Some people get them and some people don't. You put a drug on the market, you're going to give it. A lot of people with diabetes are going to get the drug. And we won't know. It's not easy to see, is it really doing good, because of the complex nature of the condition. But for an acute illness like COVID, I don't think we need to apply, my opinion, I'm not convinced that we need to apply the same standard. Evidence-based medicine's become a little bit of a religion. It's become an orthodoxy within medicine. And it's good for chronic conditions. It's good for the marketing of drugs for chronic conditions. But is it the best way to proceed during a pandemic? So let me go back to the content. So what are the treatments that currently look like they could be helping for people with COVID? There's certain drugs that actually fight the effects of a virus. And these would be things like remdesivir, another drug called ribavirin. So drugs that are manufactured by the drug industry and inhibit the biochemistry of the virus. Then there are these molecules that the immune system makes to rev up the immune system to fight. And we can give those molecules to people. And like one example is interferon. And all of these have had some suggestion, the remdesivir particularly and the interferon, that they could be helpful. And then there's a big holy grail, and that's to give the patient antibodies, to give the patient, that's why I was drawing like this in my previous video, things that bind the virus. And that would be things like convalescent serum, so blood from somebody who recovered should have those antibodies. And you could also make them in animals that have certain human cells so that they make human-like antibodies, and those are called humanized humanized animals. And then you could also make these antibodies in addition to the lab using a technique called monoclonal antibodies. And these are very likely to help. And the question is, this one, there currently is several trials going on, and the question, and they're applying something called randomized control trial, which is a gold standard of evidence-based medicine. So the gold standard of evidence-based medicine is this thing called a randomized control trial. So what you do is you take a lot of people, and then you randomize them, meaning you assign them to two groups in a completely random way. One group gets the drug, one group gets a placebo, and you're blinded. The people doing the study do not know who was blinded. Sometimes it's very complicated. Like the vials are labeled in such a way that only the study people, but not the person administering it, actually knows which patient's getting what. And then after some time, you unblind them, which means you are able to retrace, because these are all things, each vial is given a number, and there's a master list that stores whether the number was drug versus placebo. It's quite complicated. You unblind it, and you do the complicated statistics. And if you have ever looked at a paper of these randomized controlled trials, they start off with this table 1, which is a study design. And so you start off with your general group of people, and they have this thing called inclusion criteria and exclusion criteria. In other words, who could be in the study and who could not be. And then they show, how they've randomized. And there's often little loops because some people have to leave the study. And so that's always at table 1. They show the study design. And then at the end of the study, in the end of the paper, when you're reading these randomized control papers, they'll often have something that looks like this, a table that looks like this. And they divide their outcomes into the primary outcome and secondary outcomes. And then they have this chart of the relative risk. So basically, they unblind, they see who got what, and then they see what the risk of that person is to have the main outcome. So I'll give you an example. Let's say you're trying to study a drug that prevents heart attack in people who have blocked arteries. So your primary outcome will be deaths due to heart attack, for example, and you take the number of people who got it in your treatment group and the number of people who got it in your placebo group, and then you want to see if the risk is higher in the untreated people, let's say. And so they draw these curves that show the mean of the difference between the two means, the difference between the mean of percent heart attacks in the people who got it versus the people who didn't. But then they also have these error bars that show you, based on various statistics, how much, could the risk be different. And as long as it doesn't overlap 0, then there could be a benefit. But these are very difficult to do. They're complicated. They're good for things like marketing drugs to a community of people with chronic disease, like chronic heart disease, heart failure, diabetes, because you really want to tease out whether there's a benefit, and we don't really know. And it's really hard to see because you cannot observe it in real time. So it's good for chronic conditions where there's many, many different outcomes you could look at, and where the clinical picture is confusing. But for an acute illness like COVID, do we really have the luxury of time? Do we really need that threshold of statistical certainty that these trials generate? I would argue that the probability of these guys, the convalescent serum, which is direct antibodies to fight the illness, the probability of them working is so high that you should not need the threshold of statistical certainty that's generated by this level of complex study design. Also, I don't know that it's ethical to give somebody who's short of breath with COVID a placebo under any circumstances. I don't think there's very many people who would want the placebo. I think they get enrolled in the trial and they hope, because that's their only chance of getting the drug, and they hope to not be in the placebo arm. For something complicated like diabetes, where we really don't know what will happen to any given person, and it's so complicated, before you start giving, let's say especially type 2 diabetes or obesity or high blood pressure, before you start giving everybody a drug, you need to know that it'll do more good than harm. And it takes a long time. These are 10, 20-year diseases that people struggle with. But COVID is fast. It's a week or two. And some people die. So what do I propose? I don't think this study design is necessary. Why do we need this threshold of evidence when we're dealing with an acute pandemic? So what would I propose? Well, COVID has a death rate that's relatively region-specific, but it hovers between 1% to 5%. What do I mean? There's various things that you could look at, but one is just the total number of people who have had COVID, the cumulative total number of people in Ontario who have had COVID. And that'll always go up. It'll never go down because each time somebody gets it, you accrue, but it could level off. It could plateau. The next statistic is the total number of people who have died in total. And the ratio of these two gives you the death rate of COVID, the mortality. The total number of people have had it. So if one person gets it today and 2 people get it tomorrow, the total cases is 3. If 10 get it the next day, the total is 13. And then when things start to get better, when you start to get immunity, it stays. It'll be 13, 13, 13. Maybe it'll fluctuate, 14, 13, 13, etc. That's what we want to see, flattening the curve. So you have total number of cases and then total death. That number by region hovers between 1% to 5%. It's important to regionalize it because in some areas you have more care homes affected. In some areas there's certain population factors like the age of the population, pre-existing medical conditions in a given population. But if you look at all the global data, they're relatively reliable death rate that's relatively specific to the region but always hovers between 1 to 5%. This is what I propose we do. Everybody gets convalescent serum, starting tomorrow. We call back everybody who's had positive antibodies. We do antibody screening. We beg them and we get their convalescent serum. And every hospital, including community hospitals, get the convalescent serum. And then we give it. And what I propose we do is we just wait, because this thing's not going to harm very much, and COVID is harming the bejesus out of us. So what do? We give it, and then we wait. We wait a month, 2 weeks. And what we expect to see is that rate, that COVID death rate falls. Where here it's 1 to 5%, here it'll be, let's say, 0.1, or that's maybe optimistic, let's say 0.3 to 1%. So that there'll be this decline over time. And what'll mark the decline? The day we we invested the money and made the convalescent serum available to everybody. What do we do on this day? We call back everybody, we do antibody testing, we call in the people who have positive antibodies, we take their serum and we administer it to everybody who wants it, who consents. So that the threshold is based on consent, not this notion that we know absolutely with certain that a drug is beneficial. Because there's a bit of hubris in this model. This model, this evidence-based randomized control notion, means that the doctor can tell you with certainty that this pill will do more good than harm. And it's really nice to be able to have that, I would say, hubris, to say, I can tell you with statistical certainty that this pill is good for you. Here we can't. We're in the middle of a pandemic. People are dying. What I can say is, I don't want you to die. And I think this could really help you. We don't know 100% for certain, but I don't want you to die. I don't want you to die gagging for air. Let me give this to you. I don't have certainty, but I have logic. I don't have certainty, but I have logic, and I don't want to give you a placebo. And we do know at least that this convalescent serum does not do a lot of harm, and the harm that it could engender, we can deal with. And maybe we'll wait. We'll wait for the people who had really very high fever, the people who are really sick. We'll do it in an open source way. We'll do a discussion. We'll open the data. All this data will be predicated on the data being completely open. And I have to say that the health regions have been very good at giving us new cases. They're giving us a lot of data. Open it up. Still anonymous to protect confidentiality, but open it up. And let's follow the curves and trends. I think we're applying too high a standard of evidence. And I think we are underestimating the capacity to iterate, the capacity of our community to iterate based on evolving data. And so we're using a too static model that doesn't give people enough credit. Thank you.